the FDA recall that you were talking about.
Mm-hmm.
And it looks like it was only a very specific section or like lots of the medication,
Mm-hmm.
not all metformin. It was just a specific number of them.
Mm-hmm.
And they said that people that had gotten those, the pharmacy or where you got it from should have reached out if you had gotten one of those.
Oh, okay.
So it was only like a few, like wherever they were making it, there was like a contamination there. But it was only like 70 lots of it. So what I would encourage you to do is to call your pharmacy where you got it from.
And make sure I didn't get a bad lot.
Yes, just in case, like for whatever reason they tried to reach out to you and they didn't get in touch. But I would say like it would be pretty unlikely that you would have gotten it and they wouldn't have called you, or that there would be any like long-term side effects from that. But I think overall, like we haven't heard of any of our other patients having any of it, so I don't know if it necessarily, even in Columbus, if any
made
of
it to Ohio.
if it made it to Columbus.
Right.
So
okay. Well,
but that's really good. Yeah, no, that's
concerning.
very good that you are like very on top of, you know, your it's good to like look up what medications you're taking and the side effects, and
Yeah.
so you have to be an advocate for yourself.
Definitely.
Obviously, it's our responsibility to give you medications that are safe for you, but I think it's really great when patients like look up their own medical stuff, because otherwise, I mean, what do you know? Like
Right.
you never
Definitely.
know what could get missed. But I'm really glad you looked that up, because I had heard that metformin had some issues, but I didn't know like what the extent
Of the recall.
was.
Yeah.
So
Okay, well that was my biggest concern
Yeah,
with
definitely.
it. Make sure I didn't get a bad batch.
of course, so just touch base with your pharmacy. So you're still on the 500.
Yep, I
in
do
the
500 a
morning.
day
Okay.
and 500 at night.
Okay. So I would say, I mean, it wouldn't hurt to increase it to the 2 pills at night, just to give yourself a little bit better control of the blood sugars. But you said overall things have been within the ranges.
Yeah, they have. And then my only concern, like I said, every doctor tells me something
Mhm.
different. But I go do those stress tests, and they
Mhm.
said the only reason I'm doing those stress tests is because of the metformin, and it reaches my placenta. So it's not necessarily I'm against controlling the diabetes,
Yeah.
but
No.
if there's other options to control it, I would prefer to do that instead of put my baby at
Mhm.
more risk and give him higher doses of something that's the reason why we're
Right.
even monitoring him in the first place.
So that's true, but also not true. A little bit, it's a little confusing. So when you have diabetes that you're not on any medications for, you don't have to do the non-stress test.
Right.
When you're on medications, meaning it's not even because you're doing something wrong, it's just the way that your placenta is functioning,
Mm-hmm.
that you're getting your blood sugars are going a little higher, and so you need a little extra control with medications.
Right.
And so usually the 2 options are the metformin, which is the oral pill, or insulin, which is the injections. And most people are like, I don't really want to do an injection multiple times a day,
Right.
and so I'll just do the metformin.
Mhm.
But regardless of if you're on the insulin or the metformin, you have to get the non-stress test.
Right, because of the medication.
Because it's medication, and it means that maybe your blood sugars are a little bit higher, and we want to watch a little closer.
Yeah.
So it is kind of a little bit of both. It's, yeah, you're on the medication, but also because you're at a little higher risk with your blood sugars.
Yeah.
Yeah. So.
Totally not your fault, but
Yeah,
it can be control of diet, and that's
Right.
something that you don't come in the hospital and they really,
Mhm.
which I know you guys have your hands full. You have so many
Right.
different
But
jobs to do.
that's always our number one goal, is if we can get it controlled with just diet, then you don't need the medications. Obviously, it's great for you, it's great for us, it's great for the babies. So.
Right. So
yeah.
with my levels not being too high or abnormal, I just figured my last 2 weeks I will monitor what I eat very, very closely and keep my prescription where it is.
Okay, I think that's fine.
Okay.
If your numbers are getting really high, we want you to call us for sure.
I definitely will.
And we'll monitor your blood sugars very closely when you come in for delivery, because we don't want your blood sugars to be too high at the time of delivery, because that could cause your baby to have actually really low blood sugars.
Right.
So that's something we'll watch when you're at the time of delivery.
Okay.
And so typically when you have gestational diabetes, I'm sure they talked to you that we would induce you at 39 weeks. What questions do you have about that?
I'm not going to get induced.
You don't want to get induced?
No, ma'am.
Okay, and why is that?
I'm a natural person. I
Okay.
believe that our bodies can naturally do it.
Okay.
I believe God is protecting me and my son. I don't think he's 12 pounds and
Yeah.
gonna die trying to come out the birth canal.
Mhm.
I think my body's made for it, and I think I'm not totally against induction, but I would wait until he's supposed to be here to
Mhm.
force him to come.
I mean, obviously you can always have your own opinions and thoughts. But our research and our data shows that with people who have gestational diabetes, that as you get past that 39 weeks, you put yourself and the baby at increased risk.
Right. Yeah, you know that the numbers used to be different just a couple years ago. The
Mhm.
numbers keep going down and down and down.
Yeah.
So it's like, if I'm testing at 120, but 5 years ago 120 was perfectly
Mhm.
fine.
Yeah.
The likeliness in my mind that he's going to come out abnormal is
Mhm.
very small to me. Now, if I was testing 189s, 229s, 200s, then I would be a little bit more concerned. But I'm testing right in my range. I'm 79s, 98s,
Right.
101s,
Mhm.
110s, which is still kind of on the higher part of the scale. So I do
Yeah.
believe that I have diabetes, but I do
Right.
believe it's controlled.
Yeah.
And I don't want to be induced. I don't want
Okay.
an epidural. So if I go to get induced, it's going to probably make those labor pains stronger.
Not
And
necessarily.
either way,
Okay.
I just
I just
wanna
want to
let
make
my
sure
body
you
do
have,
it.
if you have any other questions about the induction or anything that we can help clarify any questions, I want to make sure that, both of us are on the same page.
Do you have
Obviously,
kids?
no, I don't.
It's okay. This is my first one, so I
Yeah.
don't hold it against
Yeah.
you. But I do believe whenever you do experience it,
Mhm.
your body's going to tell you.
Yeah.
So,
And unfortunately, that doesn't always happen to everyone. Even after we get to full term, we have people who usually we don't want people to go past 41 weeks. And we have people that are at 41 weeks and their body still doesn't go into labor. And
well, I was
born
born 10 days after my due date, and I'm perfectly fine, and my mom
Right.
was perfectly fine.
Yeah,
And I was 9 pounds, 4 ounces.
right.
So, I get everything you're
Right.
saying, but you guys have to understand, for one, the model is not
Of
individualized.
course.
It's made for a broad of
Mhm.
people, which is beautiful because
Yeah.
you guys help.
Mm-hmm.
And then on top of that, I don't know why, because it's 2020 and not 1995, the baby staying in my stomach for an extra 5 days is life or death.
It's not life or death. It's all about odds, right?
Mhm.
We can't say 100% this is going to happen. That's why we try to individualize things. But we also know that the risk increases by so much that we don't want to ever there are people that deliver past 41 weeks. Maybe they go to 42 weeks or 43 weeks, or in other countries, sometimes they don't even have that cutoff and they
Right.
do okay. But there's also such a high risk and other events happening that we don't deal with in our country because we kind of manage those risks.
You guys control the pregnancy.
We help control some of those aspects, and we also see some of the times when the outcome isn't good. There's always times.
Yeah,
when,
absolutely.
Where things go really well and there's no issues,
and times when they go really
the
wrong.
things when they
And you
go
don't want to
really
be the person
wrong.
that it goes really wrong with.
Right, and it's not even about us, it's about our patients. We care about you our patients so much.
You are the first nurse to make me feel like you care about me as a
Oh.
patient.
Yeah.
So I want to let you know that.
Well, I'm sorry you haven't felt that way.
But I do appreciate the
No,
gesture.
we really, and that's the reason. I'm sorry if you've ever felt like pressured or anything, and it's not that we want you to feel pressured. It's when we have patients that say, oh, I don't want to do this, or I don't want to do this, we think about all those patients that said that to us and then had a bad outcome.
So what
it's for
risk are you saying is
Yeah.
higher if I wait until 40 weeks to have them?
It's more that we think that the baby can't control their blood sugars as well, and that the size of the baby may be too big to deliver after.
Do you guys have machines to look at the size?
We do, but it's not, once you get past probably 37 weeks, since the baby is so big, it's difficult to
to see
measure
him.
the size. And so it can be off by like a whole pound. So we don't know, is this more like 12 pounds or is this more like 10 pounds? So it's difficult for us to tell exactly.
Mm-hmm.
So I think that's where it makes it challenging. That's what, it's hard for me too, because I can't definitively say, like, if I was in your position, this is what I would do. It's always it should be a discussion between you and me. And you know, like, you are always welcome to refuse whatever, like, our recommendation is.
Right.
But knowing that the reason that we're recommending something is because we know that there are certain risks.
Absolutely.
And especially with diabetes, even in people that have pretty well controlled blood sugars, the risk of stillbirth also increases.
But it's very small, right? Because when you guys
It's
say
still
that, you
small.
have to understand you're scaring people.
Yeah.
Definitely people that don't have kids.
Right.
So when you're like last time I came, she basically just said it like, your baby could die.
Yeah.
That was fucking insensitive.
Yeah.
But I understand you guys have a job.
Mm-hmm.
But when you just said that, like,
Yeah.
you know, the risk of stillborn. Well, girl, tell me that it's like a 0.11111% of stillborn. Don't make it seem like if you go past this week, it's a 40-50% chance that he's going to be a
It's not
stillborn.
40 or 50%.
It's very small. It's like 2%.
It is 2%, but it is much increased than somebody who doesn't have diabetes.
Right.
And that's why we bring it up. It's not to scare anyone. But
It's definitely scary.
Yeah.
Just
Yeah.
whenever, I want you just to take everything I'm giving you and try to share it with your coworkers
Yeah,
so that
definitely.
the relationship
Mhm.
between clients and nurses and doctors can start to
Right.
build.
Exactly.
So nothing is personal towards you.
Yeah.
And then with that being said, they didn't properly teach me how to test my diabetes.
Oh, okay.
So I had came in and complained 3 weeks in a row because I was getting different numbers
Mhm.
testing right back to back.
Oh, wow.
And it was
What
like,
did they figure out what the issue was?
well, the one thing that they figured out was that I was testing wrong. So for almost 10 weeks, I haven't even been
wow.
testing right because nobody
Yeah.
taught me how.
Mm.
It has something to do with the alcohol.
Oh,
It gives
okay.
you elevated blood pressure.
Right.
So they taught me how to properly test only a
Mhm.
week ago. And since then, my levels have seemed normal, at least to
Okay.
me. I'm not
Yeah,
a doctor. I
right,
believe you guys
right.
more.
Mm-hmm.
But it breaks the trust
Yeah.
when you saying, hey, you got diabetes and we're just scared. We just want you and the baby to be okay. And then I'm like, yeah, but I kind of got diabetes because y'all didn't teach me how to test for diabetes.
Yeah.
Or y'all didn't teach me what to
Mhm.
eat to not have diabetes.
Right.
Or we didn't monitor
Mhm.
when I changed my diet versus, like, you know what I'm saying?
Right.
So I understand as a whole thing, but
Mhm.
individualize my case, I feel like
Yeah.
is.
And that's definitely what we want to do, but I think it's also challenging because we have these recommendations, and you know, when we deviate from what our standard of care is, kind of the hospital, the overlying like OBGYN society wants to know, okay, why did you change what you recommended for this patient?
Absolutely.
Because you know, the last thing we'd want is for a bad outcome. Like,
Absolutely.
I really hope that you have a great outcome and you go into labor on your own and you have a great vaginal delivery with no complications. That is my hope, and it's my goal to facilitate that in the best controlled situation.
Absolutely.
And if that's not possible and that's not what you want, as far as being like more of a controlled situation, then that's okay. And as long as you understand the risks and we have discussed that,
hmm
I think that's all we can do.
Yes, absolutely.
Yeah.
Education is just the biggest,
Right.
and like it takes longer. You could have
Mhm.
came in here, checked my cervix,
Yeah,
and
right.
see you in a week. But
Right.
we've been talking for 20 minutes, and
Mhm.
you know what I'm saying. You haven't
Yeah.
even did his heartbeat, so I understand you guys are under a lot of pressure. There's so many
Mhm.
clients, but it's just something that the
Right.
hospital has to work on
Yeah.
because I'm actually planning on doing a home birth just
Mhm.
because of how uncomfortable I felt my whole pregnancy here.
Yeah.
And I'm just praying that it's the right decision. There won't be anything you can really say to
Right.
change my mind. I'll take
Right.
all information that
Right.
you want to give.
Mhm.
But, you know, no fault of anybody because it's my decision. But if
Mhm.
for some reason my home birth doesn't go well, partial the reason why I made that decision was because how I felt in the hospital.
Well, I'm really sorry you feel that way, because our number one goal of our clinic is obviously to provide the best care, but also help people feel comfortable. And
hmm
you know, we really encourage people not to have home births because we, like I said, our goal is to always have a very controlled
It's because you guys
situation.
want to control the pregnancy.
Not that we want
No,
to
that's-
control you, but that we want to give you the best outcomes
I
by
guess
being
if you're
in a
looking at it,
controlled hospital setting.
your job, so your outlook is going to be so different because you have the knowledge to why it's important to try to control. But just think of me as like a freaking hippie or something. Like, girl, we're made to have babies. You don't got to control it. Let nature work its course. Now, if nature starts acting weird, I'm going to come in the hospital and make sure everything's okay.
Well, that's, some people have home births all the time and it goes completely fine. But like I said, once again, we have seen so many patients that have had home births that have had bad outcomes where, they weren't able to have a delivery or they bled out very much and, they weren't able to make it to the hospital in time. And so for us, like, when you say you want to have a home birth, like, that's scary for me. Just like how when I tell you, like, oh, I think you need an induction.
That's scary for me.
So for me, like, when you talk, like, it literally gives me chills because I think about all my patients that I'm like, I wish I could have said something, or they tell me, like, why didn't you try to change my mind? And so for me, it's like, for my next patient, I want to, like, not that I'm trying to control you or your pregnancy,
I understand.
but I want to make sure that you have all of that information and kind of the reasoning why I'm recommending this. And like, that's why I appreciate that you're very open and you're saying, like, okay, this is why I want to do things this way or why I want to do this way, because for us that's helpful to understand as well.
Yes, definitely. When you go back, it wasn't you. If you had been my nurse this whole time, I probably wouldn't even feel different about it because it's my first kid.
Right.
So just as scared as or as nervous as it made you, it made me. But I'm telling you, the idea of you guys forcing me to go into labor sounds so much more scary than the idea of me being at home and just naturally having him. And like I said, it's an individualized type of thing. It's not for everybody. I have some trauma and some distrust with the hospital. So I just think overall that's the best decision for me, hopefully for baby. But I mean, I do still come get checked, make sure everything's okay. The stuff that's necessary.
Okay.
So.
Well, like I said, it's only my job to offer you the recommendations, and that's still going to be my recommendation, is to be induced at 39 weeks and deliver here at the hospital, because the risks are just so high with home births and also, like I said, with the gestational diabetes.
Absolutely.
If you don't want to do that, then we will just have a plan to see you next week and then just go from there.
Okay.
But like I said, I do want you to know that I am concerned about.
You can mark it in my chart. Everybody does. It's
I know,
cool.
and I just want you to know that I am concerned because like I said, I want the best outcome, and how do we have the best outcome is being in a more controlled setting, not like controlling you and your pregnancy, but doing it in what we know will give you the best chance at the best outcomes. You can still have good outcomes when we kind of stray outside of that, like the controlled situation, but the risks increase.
Yes, because it's not
with each thing that we kind of go outside of that box where we know we can control things a little bit better.
Right.
So, and I'm sure that they've talked to you about all these things, and I don't need to keep reiterating.
No, you're so okay. At least you're nice about it, because everybody else has been kind of pushy and nasty with it.
Well, I try not to be pushy, and I try to think about how would I feel. Just like you were talking about things that scare you. It's like for us on the medical side, there's other things that scare us because we see all the worst things.
Absolutely.
And we always think about the worst case scenario, which I mean the risks are low, but it is higher than we think is acceptable.
Coming and just getting an induction and being here. Absolutely.
So as long as you understand that, I think that's okay, and we'll just if anything.
And I can always the only thing that's comforting about it, like you said, first of all, if you're close. Because if you're in active labor or something bad happens, it can be life-changing.
Right, and that's the thing. By the time the spawn would bring you in or something, things can really, really change. And we would never want something bad to happen to you or the baby.
Absolutely.
Or both.
Absolutely.
In some cases, we've got, patients have gotten to us way too late.
Yes,
and
absolutely.
that's what scares us. And I don't mean to say that to scare you.
No, you're not scaring me.
But I want you to,
I make informed decisions. Where I plan on having him is next door to Ohio Health West.
Okay.
Literally, I can get up and, I don't know how that'll work in labor.
Yeah.
It's next door.
Right.
So, I mean, 2 seconds could save your lives.
Mhm.
So
Ooh.
regardless, it's risky.
Well, let's measure your belly and everything before
Okay.
you forget. But as long as you understand that, that's, all we can do. But I do feel sad that you didn't feel comfortable here.
No, please tell them that too when they ask you why you didn't convince me to pick an induction date. Let them know that my other doctors were rude and made me feel uncomfortable.
Okay. Well, I'll definitely make it known that we should work on that then. Because that's a big goal of mine. I never want a patient to leave feeling uncomfortable or with any questions or feeling like, okay, I just felt pressured into something. I never want someone to feel that way. And, it's a skill that we all work on, because it's easy, like, even when you're, like, have a fight or something with someone, you're like, why can't you just listen to me? You're just like, oh, like, it's so
And you
easy to get into
guys'
that.
job is the medical more than
Yeah.
the social work
Let me
and
get
the
our-
talking.
Yeah, and I think that's very difficult in
Yeah.
our field, because I went into medicine because I want to help people, right?
Mhm.
No one goes into medicine being like, oh, I want to just tell people what to do or
Yeah.
whatever. Like, we all have a great reason to go into medicine, but I think just the situation sometimes makes it hard. Like, our appointments are scheduled for 15 minutes.
I know. Poor
By the
thing.
time that you come in, get checked in, and then we see you, and then you check out, we have our next patient, it's like you have 2 minutes.
It's so hard for you to do.
It's so hard. And
That's why I said I don't want you to
something-
feel at fault at all.
No, and I don't. And I wish that we could make changes in our system so we could have, like, this wouldn't have been the first time we were able to have a long chat.
Little
and a
talk, maybe
discussion.
at 36 or
Yeah.
35, and then by 37, I'll be like, okay,
Yeah,
I trust y'all. We can do
Yeah.
the induction, but
yeah.
it's okay. It's not.
Okay. Well, let me get our Doppler. I'll be right back.
Okay. Increased risk, 2%. Shut up.